Hello, this is our presentation on patients experiencing shock and sepsis, which is a type of shock. We're going to also look briefly at multiple organ dysfunction, and I didn't have it up here in the title, but we'll look at SIRS as well. This is Systemic Inflammatory Response Syndrome. So let's go ahead and start and look at our shock content. So here are the objectives. The objectives are listed in your objectives and readings. So I'll let you go ahead and look over those, and let's move into our presentation. We'll begin with a case study of an unmarried female. She has some history of breast cancer, underwent a mastectomy, follow-up chemotherapy. We have some other information here, and we will discuss this in class, so please review the information, make a few notes, and we'll have our class discussion once we get together for this presentation. So to back up a little bit on shock, we have to really start with inflammation, because shock is really an extension of inflammation and is an extreme case of inflammation. So let's look at, if you recall, like at the inflammatory response, there's typically an initiating event, an injury. Say you're in the kitchen and you're just slicing and dicing away and accidentally cut your finger. So that would be the initiating event. There'd be an injury. There could be some ischemia at the area, and there's a good chance once the skin is broken there would be invading pathogens. And the typical response to that would be that there are mediators at the site. They kind of provoke the inflammatory response. They provoke the coagulation cascade, and different mediating factors, cytokines, etc., attract different white blood cells to the area so that there's protection against the invading pathogens, and there's also platelets that are activated that clots off the area and kind of saves the day. So our inflammatory response, so here's the local. We have a little mast cell there, that purple little our cell, and once that is irritated, or there's a provoking event, that actually degranulates or breaks, and that releases all kinds of very interesting mediators into the system. Like I said, there'd be a variety of cytokines and chemotactic agents that draw the white blood cells and different immune responses to the area to kind of wall it off, localize it, and make sure it doesn't get any further. However, if it does get further, if it moves throughout the tissues and maybe into the vascular system, then we have this more intensive and widespread degranulation with the different mediators, causing a widespread inflammatory response if this is released into the general system. So now we would have, instead of a local inflammatory response, we would have a systemic inflammatory response. And this would be identified as SIRS. So SIRS is kind of our precursor to many types of shock, and especially to, I shouldn't say many types of shock, I should say to our septic shocks. So here's our initiating event. Now for SIRS, typically cutting your finger while you're slicing and dicing doesn't progress to SIRS. It has to be a little bit more widespread. So here's some of our initiating events. Certainly trauma is a large event. Burns, and when I say general infection, it would be kind of a generalized infection. Our patient had a central line, our patient had a catheter. Pancreatitis certainly could cause inflammation due to the enzymes that are released and kind of moving through the vascular system. We have the individuals that are at high risk for SIRS, and it would be those individuals that have some immune system depression or other dysfunction. So our individuals that are 65 and over, those are individuals that have more difficulty responding quickly and vigorously to some assault of their immune system. If there's baseline organ dysfunction, so that would be underlying respiratory, cardiac, diabetes dysfunction, that could certainly put someone at high risk, those that are malnourished, those that are on ventilators. And you see with our patients with COVID that this is kind of the population they're saying is high risk, and to stay isolated and to be careful regarding their exposures. So this can be a known or suspected infection. If known, then it's easier to treat. If it's suspected, there has to be a little bit of detective work by the providers to figure out what's going on. And then for SIRS, we do have some criteria. And the criteria that 2 or more of these had to be present. We have a heart rate over 90, either a low temperature or high temperature, respiratory rate greater than 20, or a PCO2 via ABG is less than 32 millimeters of mercury. Now our patient in our case study, she had heart rate over 90, her temperature was elevated, her respiratory rate was elevated. So she certainly had 3 of the 4 criteria that you see below. Then the last one would be a low white count, which would indicate immune suppression, or an elevated white count, which indicated infection, or it says greater than 10% immature neutrophils. So if someone is under assault from an outside organism and they need to produce the infection-fighting white cells and variety of neutrophils, what this is telling you is if there's more than 10% of immature neutrophils, that means your bone marrow is really in overdrive and they're really trying to make as many neutrophils as possible, as fast as possible, and a greater percentage of those will be immature. So it means there's an infection, your body is desperately trying to fight it off. So SIRS is important, and this criteria for SIRS is important because you will see in the hospital, and definitely ask your clinical faculty what they see regarding SIRS, if they have a SIRS criteria, if they have a sepsis guideline that's related to SIRS. I would guess they'll talk to you about SIRS and these criteria. So here's a little depiction of what is the relationship between inflammation, SIRS, sepsis, and then MODS, which is multi-organ dysfunction. So SIRS, if we have inflammatory, that I told you it releases different mediators. One of those are cytokines. But SIRS is thought to be kind of this unchecked cytokine proliferation or storming. So this is a major inflammatory response. If SIRS is happening with infection, then it actually is sepsis. And unchecked SIRS or unchecked inflammation can certainly lead to multiple organs being infected and then multiple organs having dysfunction. And we'll look at that toward the end of the presentation. Oh, I just made a liar out of myself. Here's a little comment about MODS right now. So MODS is the multi-organ dysfunction syndrome, and it's progressive dysfunction. If it's multiple, it would be 2 or more. Here's our most common cause. And there could be primary or secondary MODS. So think about that for a minute. If it's primary, that means there's an initiating event that's so big it affects multiple organs. So certainly trauma might do that if it's a multiple trauma. Hypoxia would affect multiple organs, not just the respiratory center. It would affect the cardiac and the GI and liver and kidneys. Hemorrhage would affect everything. Secondary MODS would be there's an event that happens, and then through the course of the recovery time or attempted recovery time, then infection starts up or something provokes multiple organs to start to fail. And again, our suspicious factor would be that it's systemic inflammatory responses. There's some possible explanations, and again, does that inflammatory response and the cytokines start to storm and really become out of control? Does his tissue hypoxia then help multiple organs like fail? Is there something called uncontrolled apoptosis going on? If you remember your biology, apoptosis is this programmed cellular death that happens with all of us. We kind of reach the end of the line at some point, and our systems are wearing out. But does something trigger cellular death too early because of these different factors and the inflammation and the cellular responses? The other thing is there's some strong indication that there's a lot of microvascular coagulation happening when MODS is taking place. If there's microvascular coagulation, that means there's hypoxia happening at the cellular level. And this is a depiction of microvascular injury. So you can read the bullet points below, but the big issue is that increased inflammation is causing endothelial injury, platelet aggregation, lack of perfusion at the microcirculation. And if there's lack of perfusion at the microcirculation, then you're not going to get tissue perfusion. So this is a causative agent of our multi-organ multi-organ dysfunction syndrome, or multi-organ failure eventually. From inflammation to multiple organ dysfunction, let's look at some system-to-system issues. Pulmonary system is probably our most susceptible system. It's very delicate. The alveoli are only 1 or 2 cells thick, so they're going to be kind of bathed in any cytokines or inflammatory mediators or infection. So they're our most susceptible, and obviously we have to watch for ARDS with that. Our cardiovascular system can be affected. There's some neurologic findings, renal findings, of course, and a few others. The more organs that are involved, the poorer is the prognosis. So multiple organs involved, they're not going to have to heal based on their primary problem, but also now all the different organs have to recover for the patient to survive. And I have on the bottom there, identify markers and measures of system failure. So before you go to the next one, think about what labs or what markers, the systems that I've identified here, what would we be looking at? What would we, open that chart and let's look for what? So think about that for a moment before we go to the next slide. Here are some biomarkers. So pulmonary, does the patient need more oxygen? In other words, is their O2 sats dropping? Are their PO2s and their ABG dropping? Do they need higher FiO2? And FiO2 is, again, that fractional inspired oxygen, but what you need to set the oxygen regulator at in order to get a good response. And think about it too, if you are cranking up the oxygen on your patient, are you fixing the problem? You're not fixing the underlying problem, you are compensating for it. So if you find yourself in the situation where your patient's O2 sats are dropping, you really need to let the provider know immediately, because something's going on and all you're doing is delaying the inevitable if you keep increasing the O2 delivery system. Cardiovascular, we talked about MAP, and that's certainly very important. We also look at blood pressure. Is their blood pressure dropping? Is it less than 90 systolic? Cardiovascular too, we've got other good assessments. Pulses, peripheral pulses. How's their perfusion? Here's neurologic, and you can see altered level of consciousness without a primary injury. Renal, we have lots of good renal measures. BUN, but creatinine is better. Output, again, if they're dropping below 30, now we're threatening their kidneys. Their creatinine, if their creatinine is rising above 2 and they're not on dialysis, we have kind of a concern there. And then hematologic, if their platelets are dropping, that's very concerning because now they're not going to be able to coagulate well. If they're using all their platelets and maybe doing a lot of those microemboli, they're using up platelets, and that leaves the patient susceptible to bleeding or DIC. I think you learned that in OB. If their INR is rising too, that means they're at risk. They're using up their clotting factors. The liver, bilirubin's a good one. We also have ALT, AST. If those are rising and abnormal, that's a sign that there's liver dysfunction. And in general, if we have a serum lactate level that's rising, that's telling us that there's a lot of lactate in their system, and we'll talk about that in just a few moments. There are some MOD scores from 0 is emerging to 4 critical. That's multiple organ systems. You might see that if you're going into the critical care area. So think about this. You've seen all these markers before, but when you start to see multiples, this cascading at you, that patient is in critical condition. The interdisciplinary care of this patient, a lot of it is early, good detective work. It's prevention. It's working with your provider. It's working with the respiratory therapists. It's working with all the specialists regarding this patient. If we can catch them when they're in this early SIRS stage, let's support them with good oxygenation, fluids. Obviously, if they're septic, antibiotics. Corticosteroids are helpful just to combat the inflammation and cellular membrane instability. And then prevention, all the good things we do as far as when our patients had a major illness or event, prevent sepsis, do the ventilator-associated pneumonia prevention bundle. So that would be, VAP is elevate the head of the bed, should be at 30 or higher if possible. And then good oral care, and then suctioning and all the good ventilator interventions to improve oxygenation and reduce infection. But the head of the bed up and the good oral care is really vital for those patients. Invasive line care, that's a good line for sepsis. And then those patients at risks, good monitoring, watch the trends, and anything we can do to help improve their tissue perfusion and oxygenation, either through medications or supplemental oxygen, that's great. Here's some treatments. So adequate blood flow, good tissue perfusion, oxygenation, and again, who are our high-risk populations? We just talked about that. The very young, very old, immunocompromised, malnourished, chronic disorders. So for treatment priorities, do they have adequate blood volume, especially if this is a trauma patient? Do they have the effective pump to generate an appropriate cardiac output? And as a side to that, before you're thinking about an effective pump, you need to make sure that the pump is filled or they have adequate amounts of blood in order to produce effective cardiac output. And then do we have good peripheral tone for the capillary bed? Tissue perfusion, oxygenation, again, ABGs, O2 sats, what type of tissue oxygen delivery system, and high-risk patient identification and monitoring. Now, I'm not going to do any testing on this slide, but this is kind of a more detailed depiction of shock pathophysiology. And you can see it's heavily related to perfusion and oxygenation. But this also shows the fourth statement down, or fourth words down, talks about once we get into inadequate perfusion and there's cellular hypoxia, there's an energy deficit. and we have lactic acid accumulation. So if you think about how your body uses oxygen to produce energy, if you think about the Krebs cycle, and you think about aerobic respiration and how it produces really good amounts of energy and ATP and really drives the cells for best metabolism. Once you start cutting off that oxygen supply, your energy system goes from aerobic to anaerobic. And anaerobic respiration produces, and that would be lactic acid. So when you saw in the couple slides before, we were talking about lactate levels. That's directly related to lactic acid accumulation. That's directly related to hypoxia. So the sooner we can turn that around, that's telling us that if our lactate levels are normalizing, that means we've normalized the oxygen level at the tissue, at the cellular level. After there's lactic acid accumulation, you can see then all the different fallout from metabolic acidosis and how this becomes really kind of circular, very toxic, and then you have endothelial destruction and damage, and ultimately cell death. So it really, really is about perfusion and oxygenation at the tissue level. Now your text has a variety of classifications of shock, and we'll stick with that. So they talk about cardiogenic, which obviously would be due to cardiac or pump failure. There would be hypovolemic, then distributive, and obstructive. So the one thing I want to talk about quickly is distributive, how it says it's a relative hypovolemia. We have definite hypovolemia where fluids are lost, so that could be dehydration or loss of fluids as in bleeding. But when it says relative hypovolemia, that's telling you that your vascular system is vasodilating. So the visual I always use is if you have a Starbucks and you get like a medium or small Starbucks one day, and then you get a large the next day. I'm sorry, I can't remember if it's a venti or a grande or whatever it is. But if you would have a medium coffee or tea, whatever your choice is, if you have a medium and it's full, that capacitor, that cup is full, and there's plenty of fluid in it. So think about that as your vascular system. Everything's fine. You have what you need. It's a good situation. In distributive shock, now your capacitor or your coffee cup goes from medium to large. So if you take your coffee, your medium coffee, it's full to the top, and you dump it into the large cup, it doesn't fill the container. So that's what's happening when you have a relative hypovolemia. You haven't lost any volume. You haven't lost any amount of coffee. But by moving it into a larger container, it looks like you've lost. Like all of a sudden, a quarter of the cup is not full. So that's what happens when you have vasodilation. The vascular system opens up, and all of a sudden there's not enough volume to maintain blood pressure. And that's what happens with sepsis, anaphylaxis, and neurogenic shock. There's a capacitance issue where your cardiovascular system relaxes and dilates. And your final classification would be obstructive shock, so mechanical barrier to blood flow. And that one I can just say quickly would be as if you'd have a large pulmonary embolus and you have blood flow that's obstructed to the lungs, and then hypoxia results from that. Let's look at our other classifications of shock. So all classifications of shock go through a variety of stages. There's initial, compensatory, progressive, and refractory. And you can kind of tell or anticipate what's going to happen in the stages just by the naming of the stage. Our initial stage is like the event that starts the shock out. So it's our initial insult. You can see that there's a cardiac output disturbance. As the output decreases, the rate might go up, your stroke volume might be dropping a little bit. But the big issue is there's an initial decrease in tissue perfusion. And we have this beginning of blood lactate levels elevating because of the anaerobic respiration. It's very subtle. So initial compensatory mechanisms might start, but the signs are subtle. So this is why trending is helpful. This is why prevention is helpful. This might be the initial, blood pressure, pulse, temperature issues that we need to react to very quickly. If it progresses, then we get into compensatory stage. Now this is where your body is recognizing that maybe your outputs are dropping, your perfusion is a little lower, your hypoxia is starting, and it's all the mechanisms that happen to restore cardiac output and improve tissue perfusion. So we need to react to this pretty quickly, and this could be, again, it's all cause dependent, but we really want to make sure the patient is oxygenated, perfused, has good output. And what's happening in the body is that the sympathetic nervous system is really starting to kick in and release the norepinephrines, release renin, and then renin is what's released. It says due to the decreased renal perfusion, renin's released, and that's the whole angiotensin 1 and 2. So we get good vasoconstriction to improve perfusion, improve blood pressure. So the compensatory stage is what your body is doing to react to this. So what we have to do is, again, with our good monitoring and our assessments, have to realize that this individual's body is compensating for the perfusion and oxygenation issues, and we need to jump in and help with that. So here's some symptoms. They're a little more restless. We get the rates going up for heart and respiratory rate. They get a little hyperglycemic because they're starting to get into a little overdrive here. Their output decreases. So remember, the kidneys are not going to be salvaged if we let this go too far. Their skin gets cooler because, again, the body is concentrating on saving the core. And then their lactate levels are rising, and that's our hypoxia, that's our anaerobic respiration, that's our metabolic acidosis. And hint, hint, the sooner we can react to this, the better. Progressive then is if the compensatory mechanisms fail and our interventions are failing, or we haven't reacted quickly enough. Now we really have severe lactic acidosis. We have fluid shifting, and at the cellular damage, we have a lot of mitochondrial damage beginning, and this may not be recovery. This may not allow the patient to recover if we let this go far enough. So our kidneys are definitely being ignored. The liver and GI will kind of be abandoned at the same time as being non-essential. And with the severe cellular damage, the myocardium sometimes produces myocardial depressant factors, and that then affects the perfusion and our cardiac output. So this is getting dire here, where it might be a long road to move this patient out of this, or it's going to end up as refractory. And refractory is what it says. It's not responsive, irreversible, and ultimately ends in mortality. So assessments, some things we can be doing. It's really a good detective, our good detective skills are used to turn this around. What is the pH now? It says it requires additional information, so we need that CO2, we need that bicarb, what's going on with the respiratory system and then all the metabolic systems. If we have a lactate level that's rising, you see here greater than 5, and then if the pH is dropping uncontrollably, this is metabolic acidosis, and the metabolic portion is not the kidneys, it is the metabolic lactic acidosis from anaerobic respiration. There are base deficits that begin to show up, which is a response to the lactic acidosis. And one thing I'm not going to hold you to, but there's a venous oxygen saturation that's measured. This is not like arterial or blood gases, but this is telling you with our desaturated venous blood. Now normal venous blood is not 0% oxygen. It's usually, as you see, 60 to 80%, so much less than oxygen for often ABG. If we see that hitting like 70 or below, that's concerning, because it means not only is our saturated blood, such as with the ABGs, falling below 80, it means that also our venous blood is getting quite desaturated, and there's little additional oxygen left in the vascular system. Our treatment, here's our goals. It's all about tissue perfusion and tissue oxygenation. So what is the cause and how can we treat it, and also what stage of shock are they in? So let's start looking at some of these. We'll look at these in a couple minutes. Here's our diagnoses. You can see it's a fluid volume issue potentially. It could be a cardiac output issue. It's always a tissue perfusion issue. The patient is very anxious. There's a lot of concern with the family because these are critically ill people. If infection, it's going to be sepsis. Our general interventions, again, what's the causative agent and what are we going to do about it? Let's get additional oxygen delivery, and that can be all the way up from nasal prongs to like initial phases to mechanical ventilation with 100% delivery. Let's get that tissue perfused, and let's also decrease oxygen consumption to leave oxygen for the vital tissues. As far as pharmacology, you'll see the general approach is vasopressors, because we want to make sure that as we talk about, the pump is, we want to make sure that there's no, it's a counteraction to vasodilation. So sorry about the blabbering there. But when we use vasopressors, the big issue is always fill the pump first, which means make sure they're adequately hydrated and they have the appropriate fluids running to make sure when you add vasopressors, it's effective. So here's a couple of our vasopressors: norepinephrine, dopamine, phenylephrine. Those are all potent vasopressors. I think norepinephrine is our Levophed, but this is kind of serious when people are being run on high levels of vasopressors. Also inotropes. If you remember, inotropes increase like the strength and force of the contractility of the heart. So you might see the person on dopamine or dobutamine. I'm not asking you to memorize those or talk about those on a test situation, but just to be able to recognize these classifications of medications for treatments of shock. And there's one type of shock, which would be cardiogenic, that we would use vasodilators. And that seems counterintuitive. Why are you worrying about vasodilators when you have someone in shock after all that we talked about? So when we get to cardiogenic shock, we'll talk about that in a little more detail. So let's start with sepsis. Sepsis is a major concern. There are surviving sepsis guidelines. I was going to post those, but they're like 125 pages, so I'm just going to hold you to whatever's in the content of this presentation and in your text. The big concern about sepsis and also going back to SIRS, those kind of SIRS criteria, is those SIRS criteria kind of the initial recognized effects of sepsis. And if an individual goes into sepsis while they're under our care and we have to treat them for them, insurance companies will not reimburse hospitals for the treatment for sepsis, which can be long and expensive, because it's felt that we are the cause of the sepsis of not being vigilant enough to prevent it. So here's our epidemiology. It's got a high mortality, even higher when they're in septic shock, multiple new cases, multiple deaths. So it's a serious condition. It's devastating to the patient family, and it's also non-reimbursable. Here's our septic shock. So in order for it to be classified as septic shock, it is a causative agent, has to be a microorganism, whether it's viral, whether it is bacterial, whether it's fungal. And once the toxins get going, and if they're unchecked, all the toxins released by especially bacteria can cause a lot of damage to the tissue and to tissue perfusion and oxygenation. Here's our patients at risk. So anyone that's had their skin integrity upset, where they've got burns, where they have procedures, where they've had surgery, like our patient in the case study, if they're immunosuppressed, and then our age extremes. So the big thing is when you see those people, you should be concerned about them. Now think about people that you've seen your entire junior year in the hospital. How many of them are elderly? How many of them have underlying disease conditions? I would say that you're going to say quite a high percentage of your patients meet these criteria, which is why we're on a major campaign to reduce sepsis. Here's some other helpful visuals, and this is what one hospital in California distributes for their patients, especially if they're in that high-risk category. They've had a procedure or surgery and they go home. So call 911 if there's the fever, if they're extremely cold, the pain, the pale, or even bluish, grayish skin, too sleepy, that's our level of consciousness, and the person stating, I feel horrible, I think I'm going to die. Always listen to that. That's just like anyone who tells you they're going to die, they seem like they're finding a way to do it. So always pay attention to that. I think every single one of your professors, if you ask them, have you ever had a patient tell you this? They will all say yes, and here's my scary, scary story, and the patient died. Shortness of breath, again, that's a big respiratory component. Here's the pathophysiology, and it is what we've talked about previously, some invasion. It starts the immune response, it starts the inflammatory response, it becomes an uncontrolled systemic inflammatory response, and we have lots of damage at the tissue level. And this is where we feel that there's the formation of microemboli, especially if there's been toxins released by bacteria. And it's a real dire situation. It needs very, very quick and intensive intervention. This is part of our Surviving Sepsis campaign. I'm giving you a few things in a nutshell. And their overriding comments are to prevent infection, and treatments need to be initiated immediately in the acute phase. Now, if you see that what I've posted here, here's the little bit of a reflection back on your research class. When you see, and the key is at the very bottom, when you see the method is an A to a D, and an A is our best method, you always think, is this a randomized control trial? Now, they're doing a lot of these randomized control trials for coronavirus medications, and that's our strongest evidence that this will work. So the underlying method, we don't see any A's there. We see a few B's, which means probably more of a quantitative method. C might be more of a descriptive study, but we can't experiment on people and withhold treatment for sepsis, so we can't do a randomized control trial very well on this population. If it's 1, it's a strong recommendation. If it's 2, it's a weak. We see that we actually have a couple, mostly 1s, and we have a 2 up there. So think about your research as you look at this. So our interventions then would be begin resuscitation immediately. So it's a strong recommendation, but the research method wasn't a gold standard, but we've got good information on this. So by resuscitation, they don't mean CPR. This is the fluid resuscitation. It's fill the pump and get the cardiac output back to normal. Normalize lactate levels. And again, there's not great recommendations on it, but since lactate is a reflection of anaerobic respiration, this is part of our surviving sepsis guideline. Obtain cultures, and the obtained cultures would be before any antibiotics are given if possible. So if they've got multiple wounds and their trauma or their burns, then we culture anything that looks suspicious. If they're coughing, we attempt to get a sputum or call respiratory for that. The term pan culture, which is not up here. Anytime you see pan, we're in a pandemic right now, which means the entire world. If you see pan culture, that means, culture, if you're given an order for pan culture, culture everything that's culturable. Make sure if you have multiple wounds you're culturing, you label them immediately. And then start antibiotics as soon as possible. If you're having trouble getting something, give the antibiotics. We need to give that within an hour. Fluids. So for our interventions, we have crystalloids or colloids. We really want to keep that blood pressure up. There's the MAP, there's the urine output. Give vasopressors and inotropes. Those are the meds listed under MAP. Now you'll notice the MAP is greater than 65, so they know this person is probably going to have low blood pressures, and that's why this MAP is lower than our typical 70 that I talk about. And our 1B, our strongest, is treat the causative agent within the first hour if possible. The patient, if you think of all the growth factor and the logarithmic growth of bacteria, we've got to get in there and give medications for antibiotics ASAP. A couple additionals, corticosteroids are considered for adults, and you can see the method and the recommendation. Mechanical ventilation, obviously, treat fever, and that would help reduce oxygen consumption, conserving oxygen. There's good evidence, 1B, that glucose with insulin infusions to control the glucose levels and to keep them under 180 are real important. So that has good evidence. And at some point, if the person is in dire straits, we really have to start conversations about how much more the family wants to continue with this. And again, for some reason, I have MAP and CVP. They like a CVP over 10, which tells you the patient has a fairly decent central venous pressure. So this is our more common form of shock. I mean, I presented sepsis first because this is obviously a huge concern for patients and for reimbursement and for best outcomes for a patient. But our most common form of shock really is hypovolemic. So that is inadequate fluid volume. So this is not that it's relative hypovolemia, that there's been vasodilation. This is there's been actual volume loss. So we see here inadequate fluid, circulatory volume reduced, and therefore the metabolic needs can't be met, and it is an absolute hypovolemia or loss of fluid. So think about how people can lose fluids and become hypovolemic. So it could be severe dehydration, it could be vomiting, it could be diarrhea, it could be bleeding. If we look at hemorrhagic shock, the level of shock is really dependent on how much blood is lost. If it's lost quickly, some patients can lose a lot of blood slowly, like a slow GI bleed, or they have undetected colon cancer. They're just extremely anemic, but if they've lost it over such a long period of time, they've adapted to it to a point. But if severe, they're going to show signs of shock. Now, do not worry about the classifications, but I'm showing you, what kind of the emergency department deals with when there's been hypovolemia based on hemorrhage. As far as what they're dealing with, they might have to replace, up to 2 liters of blood on this individual to get them going. So they don't have to replace like pint for pint how much they're losing, but they would have to try to make up that volume with blood, because there's the essential components for oxygen carrying, and there's also volume, so they could certainly add normal saline or lactated ringers. Signs and symptoms: cool, clammy, blood pressure issues. They're definitely tachycardic. They're trying to keep their cardiac output going. Again, urine output, the kidneys are not going to be saved unless we get that map up. And then low output, but also low CVP. So the amount of venous return to the heart, which is measured by central venous pressure, is low. And then again, watch the serum lactate levels if they're going into anaerobic respiration. Interventions: correct the cause, stop the bleeding, and then start correcting the hypovolemia and adding colloids and crystalloids. Supplemental oxygen is very helpful. They don't have enough red blood cells, obviously, so anything we can do to add additional oxygen to the system. For nursing, if it's a post-surgical patient, they're bleeding, we really have to watch for that. The same type of patients that could be at risk, the elderly, the younger. And then, we're looking at volume, we're looking at H&H's. If we have to start blood on someone who's having a acute blood loss, we typically want a large bore needle. I think when you're doing IVs, you're probably starting at 20 or so, maybe at 22 if it's small, but an 18 minimally on this individual. They should even be a 16. We want to really roar the fluids in. What would you think a patient's position should be? So their blood pressure can be at best, and it probably should be flat. Sometimes the feet will be up, or they'll be in some kind of modified Trendelenburg, but they really want to move as much fluid to the core. Also, you might see the person come in from from the field in a mast suit, and a mast is a medical anti-shock trouser suit, and that's to help, again, perfuse the core. I'll show you what that looks like in just a moment. And this is just additional information. This is something that we do not use in the hospital. So this would be from the field. So the EMTs might put a patient in a medical anti-shock trouser. So the big concern is to get perfusion to the core. So an individual could be placed in this. You see it can be inflated like a blood pressure cuff. And it really just moves. It's like a immense SED. So the patient's placed in it, and the blood is like pushed up to the head and to the chest and thorax in order to maintain blood pressure while they're getting the individual to the emergency department. Once they're there and they can start adding fluids, they don't take the shock trousers off them immediately. It would be as the blood pressures stabilize, they could start deflating the trousers and get those off of the patient. Our next type of shock is cardiogenic. So here's some of our causes, and it's basically damage to the heart. And when the heart's damaged, it's not pumping effectively. If it's not pumping blood forward effectively, then the blood tends to back up. So these can be some severe dysrhythmias. It can be structural damage to the heart, whether it's cardiomyopathy, whether it's a acute issue such as myocarditis. It can be a severe MI. It could be that the patient will need or is on a cardiopulmonary bypass. Signs and symptoms of cardiogenic shock would be, again, there's perfusion or inability to move the cardiac output forward. So systolic blood pressure is dropping, they're tachycardic. They could easily, because of the inability to pump forward, they could have crackles in their lungs. So they're increased respirations. They might have chest pain, especially if there's an MI involved here. They would also have the lactate involvement, hypoxemia, and here is where our treatments are going to be a little different. If they're not able to have good left ventricular function and produce good cardiac output, then they're backing up into the lungs. They're also backing up then into the peripheral system fairly quickly. And that's where your central venous pressure, or the blood, the venous blood that's moving into the right atrium, is just starting to back up and the pressures are rising. So your central venous pressure rises. And this would be an intervention where we would use medications that we could potentially use as vasodilators. It's not, we've got vasopressors on here, but I'll talk about that in a moment. So it's to treat the underlying cause. So if they have an MI, if they need have a myocarditis, whatever it is, treat the underlying cause, but monitor and then treat the cardiac output. So our best monitoring would be kind of an arterial monitoring and potentially like a subclavian monitor with the Swan-Ganz that could give us cardiac pressures and pulmonary pressures and maybe CVPs. So don't worry too much about that. It's just that we're monitoring their output via different methods, and blood pressure is a big one. But also we want to increase the cardiac output, so we could do like support the pump function of the heart. They're the inotropic agents. We could give vasopressors, but what I don't have on here is we might want to, for a while, make sure they have vasodilators so it drops the central venous pressure. So we'd more likely give inotropes and vasodilators. So if you could just make a quick edit on that. And then medications that decrease afterload, those would also be our dilators right there. They could put them on a device called an intra-aortic balloon pump, which helps move the blood forward. And certainly they could use mechanical ventilation if they're severely hypoxic. So let's look at the balloon pump for just a second. And here it talks about, I don't need you to know the function of the balloon pump, but the nursing responsibilities would obviously be something I'd want you to know about. The pump is usually placed in the femoral artery. So with that, they should only have their head of the bed up maybe 10%. If the person wants their head of the bed up more, they actually tilt the whole bed so the head is up and the feet are down a little bit. But the angle of the patient's head on the mattress should never be more than 10%, because we do not want to damage the pump in their femoral artery or cause bleeding. It's a big artery we're in. Check the dressing for bleeding. Check the peripheral circulation on the leg that the pump is in. And then make sure we have good perfusion from the pump. So I have another, you see there's a comment there about the balloon increases blood flow. Let's look at another picture about that improving blood flow. So here's the intra-aortic balloon pump, IAPB. And you'll see during diastole or during rest, the balloon actually inflates. So as it inflates, you can see at the far end of the balloon, it's actually, the inflation helps push more fluid out into the circulation. Now there's also an arrow going back into the heart. And when that happens, it helps keep the ventricle well filled so it can have a better ejection fraction. It also, you can see there's some little arrows that move up to the head, so it's improving the circulation to the cerebral circulation. And then when the heart beats, the balloon immediately deflates because we don't want to block the cardiac output from the heart. So this is synchronized with the heartbeat. It reads like the rate, and it inflates during diastole or rest. It deflates during systole. And again, once it's deflated, the heart beats, the blood moves through the aortic arch, down into the aorta past the balloon. When the heart rests, then all of a sudden the balloon inflates, and it helps push the blood forward to kind of give it a little more of a kick. It also takes the blood that's kind of left in the arch and either moves it back into the ventricles or up into the cerebral artery, the cerebral circulation, and kind of helps fill the ventricles so they have a better output, and then it repeats again. As the patient gets better, they can now start doing like every other beat is assisted with a balloon pump. And as they're improving, maybe every third or every fourth. So as the assistive device, as the heart heals and the assistive device is not needed as much, the ratio of inflation of the balloon will start decreasing because we don't need the assistance as much. So here, I'm not going to hold you to the actual mechanics of the intra-aortic balloon pump, just the overall purpose, and then our nursing care. Another kind of shock, anaphylaxis. I'm sure you're fairly familiar with this. Low levels of anaphylaxis are just like hives, and that would be an allergic reaction. Anaphylaxis, however, is life-threatening because it affects our respiratory system, and it's typically a hypersensitivity to an allergen. So think for a moment, what are our allergens? You see one there up in the corner. So it certainly can be foods. And you see nuts up there, tree nuts or peanuts. It can be insect bites. I know some people are severely allergic to bee stings. It can be different chemicals or dyes. And it's a severe hypersensitivity. It causes generalized vasodilation, which is that relative distributive type of shock. So all of a sudden their blood pressures are normal, they vasodilate, and their blood pressures drop severely. Increased capillary permeability. So this is where we get like blistering or hive-like responses, either on the skin, but if it's like a swelling in the respiratory tree, that's very concerning. It can cause decreased myocardial responses and smooth muscle responses, but our big concern is that edema of the respiratory epithelium. And I think you know what the person should be carrying if they have risk of anaphylaxis. Causes, here's the chemical causes. Causes a release of histamine. And strangely enough, an antihistamine is way too slow reacting. So we do not use antihistamines as first line for a severe anaphylaxis. If they have a reaction like you see below, where we've got blistering on the skin, that could be a histamine, an antihistamine could be used for that because it's local. I'm sure that's extremely painful and itchy, but as long as it's not in the respiratory system, that could be, we could use an antihistamine for something like that. The common allergies, drug allergies, venom, food. The little picture I'm showing you, this was a warning a couple of years ago that henna was being like infused with a really dark, almost black dye to make the henna last longer, except the dye was highly allergic to many people. So they'd start with the henna, and then shortly afterward, they would have the pattern of the henna would be replaced by these blisters everywhere. So here's our signs and symptoms. It's really our anaphylaxis are really concerned about our severe hypotension and respiratory issues. If a patient presents, they're more likely, if they're in severe state and having severe difficulty breathing, to intubate them sooner rather than later, because if it's later, they might not be able to get in. If the airway is so tiny and constricted, there's not much they can do, even if they try to trach them. That airway is going to be too small to do a lot with. So you can see very flushed because they're dilating, they're sweating, edema of the airways, and it is an urgent condition. So our medication would be epinephrine. So they should, if they've been diagnosed previously, they should carry their EpiPen with them. And as you remember, they deploy the EpiPen. They don't worry about, going through clothing. They just go right into their thigh, and they hold that EpiPen for 10 seconds to make sure it goes in, and they should go to the emergency room as soon as possible. So here's our interventions. It says good history, good brief history. Are you allergic to anything? Bees? Okay, come on in. Vital signs, get that trend. Prepare for intubation. If they start taking a turn, you don't want to be looking for equipment. Lots of fluids to kind of keep their cardiac output up. And then epi. Benadryl and steroids would be then a secondary medication. They're not as quick acting, but this will help stabilize things for when they're discharged. Bronchodilators, that's a very helpful solution as well. Get those airways open. And then we have neurogenic shock. So this is loss of suppression of the tone because of a spinal cord injury or disease. Sometimes this will happen after general anesthesia, but it's very similar to spinal cord injury, and it's usually like thoracic levels on up. So signs and symptoms, again, you get this vasodilation. The vessels have more capacity, their blood pressures drop, therefore they get hypotensive. Now, different from the other shocks, instead of tachycardia, they get bradycardia. And this is kind of the, due to the spinal cord injury, the balance between parasympathetic and sympathetic responses are lost. So you get almost the parasympathetic overrides this. So the big response to this, and almost the identifier, is if they're bradycardic, we're concerned about neurologic or neurogenic shock. Their skin is warm and dry because of the vasodilation, but with all that vasodilation, they're losing a lot of heat. At some point, then they start losing too much heat and they become hypothermic. So that's another sign of neurogenic shock. It also points to our intervention. So let's look at some more of this. So careful fluid administration. The vasopressors, and we have to make sure their cardiac output is in good shape. Atropine, what would that be for? Think for a moment. We had this under cardiac dysrhythmias, and this would be for symptomatic bradycardia. And then also environmental temperatures. Now think of it, if they're in with neurogenic shock from a spinal cord injury, they probably had a trauma. So again, with trauma, we want to look at them from head to toe. And once we take all their clothes off, they're going to get cold. So either the ER room has to be warm, which it's not, but those warm blankets are very helpful for this population. So that is our shock discussion. I've put a couple slides at the end of this. I'm not going to talk over them, but you'll see kind of a graphic depiction of the different stages of shock. There's 5 in this the visualizations, but some people like them, some people like, just extra information. But at least you can see the trending, curving of different elements of assessment for patients, the lactates, the blood pressures, the pulses. I was going to just delete it, but it's for your information, and if you want to look at that. Otherwise, this is our Tuesday presentation. Bring your questions on Tuesday regarding shock. And then on Thursday, we'll have immune deficiency. There'll be 2 sections. There'll be HIV/AIDS and there'll be oncology. Those may not be posted until closer to even Tuesday. I'll see how my time is. I'm working on all the exams. So have a good day. Stay safe. Stay safe. Hope to see everyone soon. And look at those extra slides if you wish. But otherwise, that's it for today. Have a good day.